University of Arkansas from Little Rock, the same place as Rupa's. So my cases are more of companion cases to some of the cases we saw last Tuesday. This is the first case, 37-year-old female with a pelvic mass. We have the MR images. We have a lobulated, well-circumscribed, very T2 hyperintense mass in the right anterior pelvis that extends through the inguinal canal into the mons pubis area. It has these fine, thin linear septations inside, some phlovoids, suggesting that this tumor is vascular, hypo on T1 weighted images, and these are the post-contrast images, arterial and delayed images. So any guesses on what this could be?
Gitanjali, I'm thinking about my solitary fibrous tumor.
Yes, that's what.
Alina's a myxoid tumor too. That's a great choice for something that's very T2 hyperintense.
Yes. So these were the differentials. Actually, I didn't think of solitary fibrous tumor in this case. So the differentials that we were considering were, the top differential that we were considering was an angiomyxoid category of tumors, which includes aggressive angiomyxoma, angiomyofibroblastomoma, and cellular angiofibroma. I think the aggressive angiomyxoma has these more classic Ant-Mini type of appearance, that it's a deep pelvic mass that extends into the perineal soft tissues, typically seen in middle-aged females. And these are just tumors on the similar spectrum, more vascular, but they're usually more benign and smaller in size, typically less than 5 centimeters. And aggressive angiomyxomas are typically more than 10 like larger tumors up to 10 centimeter in size. And just thinking of differentials like pelvic tumors in middle-aged, in that kind of demographics, the other differentials were a leiomyoma, lipoma, and a solitary fibrous tumor. So we actually, based on this very T2 hyperintense appearance and internal septations, which are linear, and the mass being that is extending from the pelvis into the perineum and intensely enhancing, we actually thought of an aggressive angiomyxoma, but the biopsy on this one turned out to be solitary fibrous tumor. So in retrospect, I think it's the, I mean, obviously demographics help that in a middle-aged person, you have to think of this tumor, which is something that is well circumscribed, but very intensely enhances. And it shows this classic delayed enhancement. So just reflecting that it has fibrous component in it, in a loose myxoid stroma that forms the background. So should have think of solitary fibrous tumor, which we didn't in this case. So this was a solitary fibrous tumor. And we also have a case of liver SFT. This is exactly the same case that Aarti showed last time. Again, I think whenever you see this progressive delayed uniform enhancement in a lesion, you should think of a solitary fibrous tumor.
Gitanjali, actually go back one point I would make is that this one looks also like T2 dark. And
yes.
I've been fooled in the past with, like, if it's the very T2 bright ones, both with solitary fibrous tumors and with desmoids or fibromatosis. And my conclusion is that they can be either. They can either be quite T2 dark, like fibrous looking like this, or they can be really, really bright because of the collagen. So don't say like, oh, just because it's not T2 dark, it's not a fibrous tumor.
Yes, totally agree with you that the T2 appearance is very variable. If the fibrous component is more, it's T2 dark. If their cellular myxoid background is more, which then it becomes very T2 bright, but it will always show this delayed progressive post-contrast enhancement. So I'll not get into the theory part, which we have already discussed. The only thing is our pathologists are really, like the way they describe these soft tissue tumors is they talk a lot about these immunohistochemistry markers. So one thing to remember about solitary fibrous tumor is the STAT6 nuclear reactivity, like similar to MDM2 for atypical lipomatous tumors. So I think just few good immunohistochemistry markers to remember